Yeah, hello everybody. Can you hear me? Okay. I think there are many people who are participating. I'm very happy for that. Thank you very much for joining our first NextGen webinar on suicidality and psychotherapy research. And I'm very happy that Sarah Bloch-Elkouby and Andrea Häfliger will present today. And Sarah is professor at Yeshiva University and integrates suicide prevention research with psychotherapy process and outcome research. And Andrea is a PhD candidate. If I'm right, she will finish soon. And she works at the Multicast project at the University of Zurich. So we've got around 1 hour today, and we will start with Sarah first. We've got around 20 minutes, and after each presentation, we've got around time for a few short questions, 2, 3 questions. And if we've got some more time in the end, we will make a short discussion. Okay, Sarah, if you're ready, you can start. I'm looking forward to this.
Wonderful. Thank you so much, Tobias. Thank you all. This is such an honor to be invited to present at this SPR NextGen webinar. I think that this invitation very much illustrates what a wonderful community we have at SPR, because Tobias and I met at SPR. Galit, I met you at SPR as well, I believe in Poland. And so thank you again. I am going to try to make the case for the integration between suicide prevention research and psychotherapy research. This may be obvious for some. People may already be convinced. If you are convinced, then I hope that this will bring up some interesting food for thought. And if you are not convinced, I hope that this will be interesting as well and hopefully thought provoking. So first, I am going to talk about some wonderful, sorry, the sharing window just closed. I'll be right back. One moment, please. Okay, it looks like I am encountering technical problems. We knew this could happen. We didn't know it would happen that fast. So Tobias, would it be possible for Andrea to go first?
Andrea, are you spontaneous? Are you ready?
Of course, yes.
Excellent. Thank you. Much appreciated.
Nice.
All right. So let me share the presentation. Okay. Can you see the presentation now?
Yes.
Yes.
All right. So thank you also from my side for inviting me. I'm very happy to present here today, basically my PhD project. And this is the first time that I'm bringing together all of the different sub-projects. So it was quite exciting to see all of this, actually. So yeah, this is about promoting self-efficacy to manage suicidal thoughts and behaviors, and also about the development of a digital approach based on these self-efficacy trainings that we are now talking about in this presentation. Okay, so first let's quickly look at a 2020 meta-analysis where the authors investigated the effectiveness of interventions for suicidal thoughts and behaviors over the past 50 years. And there they saw that the effect sizes were rather modest, and also that there were no improvements or very little improvements over these 50 years. So we do need novel approaches for the management of suicidal thoughts and behaviors. And there are different avenues that we can work on. First of all, we can look at the mechanisms of change and look at which mechanisms we target. And also we can basically look at the modality of delivery. and see whether there's different options that we can use there. Now, for our multicast project and for my PhD project, we decided to use both approaches. And in terms of mechanisms of change, we basically wanted to mainly focus on self-efficacy. So this is a transdiagnostic intervention mechanism, which nicely aligns with the transdiagnostic nature of suicidality. And several studies have already established the association between self-efficacy and suicidal thoughts and behaviors. And so far, there's been no studies that specifically looked at intervention that's trying to target self-efficacy in order to manage suicidal thoughts and behaviors. Now, as for the modality of delivery, of course, in the past few years, there have been more and more studies on digital interventions, and they also hold a lot of promise for this symptomology that we'll discuss here. On one hand, we do know that suicidal thoughts fluctuate a lot over a short period of time, so timely interventions are very important, and digital interventions do have the opportunity to deliver that independent of time and place. Also, we know that there are specific phases where the risk for suicidal behavior is particularly high, for example, after being discharged from a psychiatric hospital. And also here, digital interventions are able to help ensure the continuity of care when transitioning from inpatient to outpatient care. And lastly, digital interventions offer an accessible and also a low stigma entry point to support. And as we know that suicidal thoughts and behaviors still are highly stigmatized, this is also a very important point. So we see here that digital interventions are a good way to accompany like existing intervention approaches and basically use that as a package. Now, for our project, as I mentioned, we wanted to work on both mechanisms of change and modality of delivery. So the project aim here was to develop a digital intervention that incorporates specifically a module that targets self-efficacy. And as Tobias mentioned, we do that in the multicast project. This is a large-scale interdisciplinary project about the prediction and management of suicidal thoughts and behaviors. Of course, this also is a big aim, and we need several sub-projects to accomplish this aim. And I will now give you a quick overview over the three parts that make up my PhD project. And I will, of course, give you some insights over all of these parts throughout this presentation. So in part one, we looked at an autobiographical self-efficacy training and investigated whether it's a promising candidate intervention for suicidal thoughts and behaviors. So we wanted to see whether it engages actually with constructs that are associated with the symptomology. And then in part two, we took the next step and then translated this autobiographical self-efficacy training into a digitalized version. So we wanted to create a chatbot out of this. In part three, then, we incorporated this chatbot also then in a multimodal smartphone app to accomplish our main aim. To have this product, this app for individuals with suicidal thoughts and behaviors. Now let's start with part one. I already mentioned this autobiographical self-efficacy training, but what exactly is that? It includes a vivid recall, basically, of autobiographical mastery memories. And the idea is to really have a deep recall of such self-efficacy memories to boost your current sense of self-efficacy based on these lived situations. There have been several studies that have already investigated this type of training, and they found a lot of positive effects. For example, and these effects are across different psychopathological domains. In this first study, they found a decrease in distress and negative affect, and also improvements in coping in torture survivors after they viewed pictures that were associated with trauma. And also in another study, they investigated a PTSD sample and found improved social problem solving. So now about the structure of this training. It's in all of these studies and in the study that I am now presenting, it was in an in-person format. And first, the participants always just recalled and retold the memory, just everything that came to their mind. Then in a second step, the experimenter would ask some follow-up questions to make sure that the memory recall reaches a certain depth. And then in the third step, the participant would then identify some specific strengths, so abilities or characteristics that help them or help that the situation became a success. And this was then repeated for 3 memories. So within this training, the participants recalled 3 memories in total. Now, in our experiment, we wanted to see whether the self-efficacy training engages specific precursors of suicidal thoughts and behaviors, specifically perceived burdensomeness and thwarted belongingness, as postulated in the interpersonal theory of suicide. And for that, we recruited 105 healthy young adults. When they came to our lab, they first filled out a few questionnaires and measures of perceived burdensomeness and thwarted belongingness, and then they were randomized to one of 3 groups, either a group that recalled 3 self-efficacy memories, a group that recalled 3 neutral memories, or a group that did not engage in any memory training at all. The 2 active groups then had a T2 measurement, and then all participants took part here in an interpersonal stress task that induced feelings of perceived burdensomeness and thwarted belongingness. And this was then followed by another measure of these precursors. And we then had the goal to compare the changes from T1 to T3 between our 3 groups. And this is what we can see here. We see here that the self-efficacy group had the lowest increase in both of these precursors compared to both control groups. And when we look at the statistics, and here we compared the group means at T3 while controlling for T1, we saw that the self-efficacy group had a lower level of perceived burdensomeness compared to both control groups, and a lower level of thwarted belongingness compared to the no training group. This is here in blue. So all in all, we saw that there were some attenuated increases in these precursors. They were a bit more pronounced in perceived burdensomeness than in thwarted belongingness, but we saw these even after a single session. And we also found some other positive effects on specific self-efficacy domains and also on physiological responses, so heart rate variability. But unfortunately, I do not have the time to talk about this today, but feel free to scan this QR code and check out our preprint. So the conclusion that we draw from this first part is that this autobiographical self-efficacy training is a promising candidate intervention for people with suicidal thoughts and behaviors. And based on that, we then went over part 2 and decided to translate this in-person format that we had to a digital format. We wanted to create a chatbot. We had some challenges that we needed to address. On one hand, we needed to adapt the structure for everyday use, because in the lab experiment, we saw that such a memory recall session was between 15 and 30 minutes, and this is just simply too long to be an ecological digital intervention. Then second, we wanted to make sure that the vividness of the recall is still maintained in this digital version. And third, this digital version now is supposed to be used and practiced repeatedly. So now we do not only want to conduct a single session with this training, so the user should stay engaged across multiple sessions with this training. The first point we addressed by reducing this training to only 1 memory per session. We still collected or want to collect 3 such memories so that we can rotate between the memories. The second call we addressed by integrating large language models, for example, in order to make sure that the follow-up questions that are being asked by the chatbot are actually matching to the context of the memory and they're not just generic nonsense questions. And for the third part, we also used LLMs, and the idea here was to add a variation to the chatbot messages so that they do not always sound the same, and that the conversation or the interaction is a bit more lively. Of course, if we use LLMs, we always need to consider user safety, and specifically with this vulnerable population. So we decided to go forward with a hybrid chatbot architecture. This means that we combined a rule-based approach with some LLM aspects. This means the structure of the training is preset and predefined and cannot be changed by any LLM inputs. However, the evaluation of the user input and also the generation of the chatbot messages is supported by LLMs. And I will give you a quick demonstration of that right here. Before the participants start with the actual training, we have a preparatory session. And here we collect the 3 memories that will then be recalled during the training sessions. The chatbot would start with a greeting and also with a quick few facts, just some psychoeducation about self-efficacy in order to explain to the user why we do this training and why we want to promote self-efficacy. The user would, of course, be happy and wants to start. And then the chatbot would ask the user to try to think of a suitable memory. Suitable memory here means that it needs to include a self-efficacy component. The memory duration should be no longer than 24 hours, and it should be a distinctive event. The user then might say something like, oh, 2 years ago, I went to the circus. Of course, this does not really entail a self-efficacy component, and the LLM now here comes into place, evaluates this message, and then also immediately generates a response that fits this specific context and tells the user, unfortunately, this memory is not suitable. It does not entail something that you have mastered. Can you name something else? Then the user would name another memory, and this time it's suitable. The user was super scared to start a new hobby, but he or she did it anyway. The LLM again evaluates this message and then comes to the conclusion that this is a suitable memory. It would then also check how many memories were already collected. Right now we only have 1, and then it would ask for another one because our goal is to have 3 in total. And this would then go on until we have 3 suitable memories. During the training session then, the chatbot would, of course, again, greet the user and then immediately prompt the user to talk about one of the memories that were collected. Right now, the chatbot asks the user to tell the chatbot about the memory starting a new hobby despite fears. The user would then start and write everything down that comes to their mind, like, oh, I wanted really to start learning ballroom dances, but I was so afraid that I would embarrass myself. Now, with all of this text, the LLM again comes in and evaluates it and compares it to a set of categories. These categories include things like cognitive processes, whether those were mentioned, affective processes, or interpersonal aspects. And the chatbot would then check which of these categories were not mentioned yet and phrase a suitable follow-up question that matches the memory. For example, so what were your thoughts throughout the class? The user would then give an answer, the LLM again evaluates it, and then asks another follow-up question, because it usually comes up with 2 to 3 questions to make sure that the user actually really engages with this memory and maybe has to think about some other aspects than those that immediately come to mind. Right now, it would ask about interpersonal aspects, like what or how did your dance partner react? This would then go on until the chatbot would be happy with the memory recall depth, and the chatbot would then ask the user to name some specific characteristics or abilities that help them to master this situation. Then it could always happen that the user says something along the lines of, no idea. Do you have any examples? And this could also happen, for example, during the preparatory session when we are looking for suitable memories. The LLM would then again also recognize what is happening in this message and would generate a response with some examples of such abilities or characteristics or strengths. And these would then actually match the memory that is being discussed in this session. So again, we do not have any generic examples here that might not even fit the context. And as soon as the user would then decide on a suitable strength, the training session would be concluded. And if the user comes back, then the chatbot would prompt the user to recall another of these memories that were collected. So to sum this part up, we right now have a first version of this chatbot. So we saw that the technical implementation of this hybrid architecture is feasible, and we are currently collecting clinician feedback and waiting for the responses to hear whether they think that this is suitable for an application in everyday life. And the next step would then be to get also feedback from people with lived experience as well. Now let's move over to part 3, and this is now where the whole app, the multimodal app, comes into play. So our aim was to create an app that covers different phases of symptom severity. So we did not only want to include crisis intervention parts, we also wanted to have some modules that could be applied during stable phases. We wanted to make sure that this app is built on stakeholder input, and we also wanted to combine some evidence-based approaches with some more innovative modules. And we then came up with this structure. In terms of crisis intervention and also an evidence-based module, we decided to include a safety plan module alongside then, of course, the self-efficacy training, which in turn is more for stable phases and also is more on the innovative side in terms of module selection. From our stakeholder inputs, where we conducted interviews with clinicians and people with lived experience, we identified a wish for a diary card function or a symptom tracking function, and also meditation exercises. And we decided that we will take up these modules as well. So this is now then our first version of this multimodal app. And as you can see here, the creation of the safety plan and also the training sessions of the self-efficacy training are both LLM assisted. Now, the idea here is then to conduct a feasibility study with this app, and we want to include inpatients from the Psychiatric University Hospital here in Zurich. The participants should be between 18 and 65 years old and German speaking, as we only have a German version of the app as of now. And of course, all of them should have a history of suicidal thoughts and or behavior. Now, while they are still in inpatient care, the participants would sign the informed consent and conduct some baseline assessments and also the app onboarding. So the creation of the safety plan and also this preparatory session of the self-efficacy training would all happen while they are still in inpatient care. Now, when they are discharged from the psychiatric hospital, the app would then basically start working. We would have 3 to 5 daily prompts per day, where the participants are asked to enter information about the current symptom severity and also about the presence of warning signs that were defined in the safety plan. And depending on whether the warning signs are present or not, the app would then suggest different actions. So if the warning signs would be present, the app would then suggest opening the safety plan, and if they would not be present, the app would then rather nudge the participants towards the other modules like the self-efficacy training or a meditation exercise, for example. All resources are, of course, also available on demand, so they are not only available depending on whether they answer the questions about the warning signs or not. They can immediately go and start each of the module. And we would also incorporate a dedicated crisis support page on the app where emergency numbers are saved with a direct dial option. And also the safety plan will be linked there. Then after 14 days, the participants would again come in to fill out some questionnaires and also would conduct some interviews to get information about the usability and acceptability of our app. And we are currently also thinking about including a 1-month follow-up. So, of course, we are still very much in the development phase of our app. So to give you just a quick outlook from this feasibility trial, we hope that we can identify some areas of refinement, for example, about the duration of the the app use, or also about the avatars that we plan to incorporate, avatars in terms of like a coach that guides the participants through the app. Because we had already a lot of discussions within the team whether we should use human-like avatars or not. So this is something that we would definitely be curious to find out. We definitely want to know more about the module selection, whether this actually is suitable or whether something is missing, and also then about the timing of the prompts. And of course, this whole feasibility study would then inform potential next steps. Either this could be an additional feasibility trial, or of course, if we are ready, then also we could take the next big step and plan an RCT. So to give you again a quick overview over these three parts, we had the lab experiment about the autobiographical self-efficacy training, and the analysis here is basically complete, but we plan a secondary analysis about the memory narratives that we recorded during the experimental session to see maybe which types of contents are associated with higher increases in self-efficacy. Then for part two, the creation of the self-efficacy training chatbot. Here, as I mentioned, we are still waiting to complete the evaluation, and potentially maybe we would also tweak a few things depending on the feedback. As for part three, this is the one that we are still very much in the middle of preparing everything. So we are still completing the app development. We are writing all of the dialogues that are then incorporated within the app, and also create a whole design. And as I mentioned, we are discussing many things about the feasibility study, and we are currently putting down the details about this. And with that, I'm already at the end of this presentation. Thank you very much again for inviting me and for your attention. I'm happy to take some questions, I think, now. And if you ever want to just exchange on any of these topics, please feel free to email me.
Thank you very much, Andrea. Very great presentation, and I especially like the point that you integrated lived experience experts, and I think it's very important. So we don't have much time for questions left, but maybe are there one or two brief questions?
Hi, just a quick question about what exactly is the LLM model that you use along the process. Thank you.
We have tried different models right now. I think we are working with a GPT model, if I'm remembering correctly, but I would need to check where we landed at right now, because we tried out a few different things also with our server setup that we have here in Zurich. So we had to adjust a few times. But if you're interested, we could also get in touch via email.
Sounds good. One follow-up question, if you do have time, we do have time to answer that. Because GPT tend to evolve and they change without telling us about it. So if you're using the latest model, the generation will constantly shift unless you're using GPT OSS or a version that's not evolving. So do you pay attention to the model they're evolving itself?
Mm-hmm. So we would definitely go with a model, or we decide on a model and do not constantly go with the newest version, also considering that we want to have the same experience for everyone within the feasibility trial. And if this spans over a period of time, it would not be wise to have some types of changes in there. And also for evaluation, of course, it's important to evaluate everything with the same model as well.
Thank you.
Hey, I see another hand of Denise DeFay.
Yes. Hello. Thank you for your presentation. I think it's very important to do research on this since it's coming, but on the other hand, it's very dramatic that we should have APPs instead of neighbors and friends. So this is terrible from a sociological point of view, that this should be so present in our everyday lives and the absence of bondings. But I would like to make another comment because I'm a very old member of SPR, and I remember a time when the coaching societies approached SPR, especially David Orlinsky, because they were very worried about the suicide after the coaching processes in this sort of self-efficacy approach. So this, I think, should be taken into account because they had the model is very much in that style, in this sort of supportive interventions, but without exploring the conclusions they had were that why the suicide? There was insufficient exploration of the reasons to fail in life, and there was an insufficient also exploration of the real capacity to take these encouraging interventions and transform them into something. And this sometimes came as an extra burden, thinking that others tell me I can and I can't. So, and the other thing is that in many cases of suicide, the causes are not in the person, but in his life conditions, like sexual exploitation, for example, or forced migration. So this can be felt also as a lack of understanding of where the real problem is. It's not in my self-efficacy, but in the world which is punishing me or pushing me out or exploiting me. So these are considerations to take into account. Thank you.
Mm-hmm. Thank you very much for your comments, and I think they're all very, very important. I think from our point of view, or how we see this project, is always as a complementary approach to existing therapeutical interventions. So especially for the feasibility study that we are planning, each person should, of course, still stay within the psychotherapeutical care. That's so basically treatment as usual. We would absolutely never remove that and replace that with a chatbot. And I think you made also a very important point of replacing actual humans with a chatbot. And this is somehow reflected also in our discussions that we have had within the team, whether such an avatar should be human or not, to make sure that this chatbot is not actually seen as another human being, but that we use just LLM to help them engage with these types of trainings. So yeah, but as Olive, you mentioned, all of these points are very important. And maybe I could also just quickly add, we are currently, this is part of another PhD project of one of my colleagues, where we look at the self-efficacy training in a real-life setting as a group intervention within the Psychiatric University Hospital. And of course, the learnings that we get from there would also then be integrated within our app.
Thank you very much for the comment and also for the answer. There's also another very interesting question in the chat. I would like to maybe talk about it in the end, or I don't know, Andrea, if you've got time, you feel free to answer it also in the chat. Yeah, but I would like to go on with the next presentation. And Sarah, yeah, you can share your slides.
Okay, it seems like this time, hopefully, you will be able to see my slides, and we're going to cross our fingers very strong so that we don't have any additional technical issues. I do want to say, Andrea, that I really enjoyed your presentation. You will see that there are a lot of interesting bridges that could be made and that could be discussed. So I think that based on this presentation, I probably don't need to make such a strong case about why we would need to integrate psychotherapy research and suicide prevention research. But we're nevertheless going to take one step back and try to think in terms of, with a macro vision about those two fields of research and the different areas in which the skills that people in this group have, skills of psychotherapy researchers, can really, really enhance suicide prevention. And we will look at it from several angles. We will look at three very important issues that the field of suicide prevention research is facing, and that seem to be very, very difficult to address. Patients' disclosure, I should actually say patients' non-disclosure, We will talk about this in a minute. Patients' tendency to refrain from sharing their suicidal thoughts with their clinicians. Very significant problems in risk prediction with prediction models, with prediction models that are not as effective as we would want them to be, as well as problems with effectiveness of our interventions. And the presentation that we just saw is hopefully going to address some of this. So basically what I'm going to try to reflect on will be, can our tools as psychotherapy researchers help the field understand and address these challenges? But before I start, I obviously want to make a lot of acknowledgements. First of all, to all the students, research assistants, my lab manager, the research coordinators in my lab. They are all very much part of this research program, and I'm extremely grateful for their hard work. I also, of course, want to mention and thank my main collaborators who used to be my research advisors, one in my PhD studies and the other one during my postdoctoral fellowship. And of course, I want to thank and make an acknowledgement about funding disclosures. So, with that being said, let's think for a moment about these two fields of suicide prevention and psychotherapy research that have evolved separately and very often use different methodologies. That you can see on this slide. We're going to be quite quick about these, but I would say that their main common interest in outcome assessment. Besides that, they very much look at different aspects of human functioning and psychotherapy functioning with different methods. And the question that we're going to ask is, would it make sense to integrate between those two fields? And if so, what would integration look like? The model that I would like to propose is a model that would basically use the field of psychotherapy research, and more particularly this idea in psychotherapy research, whether we look at process research or outcome research, that we're very often interested in understanding patient factors, clinician factors, and dyadic factors, whether we're talking about process, about change mechanisms, or about outcome. And so let's see, with regards to these three problems, very briefly, how would that look like and what can we learn from implementing this type of approach? Let's start with patient's disclosure. And again, I'm mentioning disclosure, but the reality is that we're mainly talking about the problem with non-disclosure. There is an emergent body of research that shows that patients tend to not disclose, to refrain from disclosing suicidal ideation, whether it is out of minimization, whether it is concealment. There is an emergent body of research on this topic, and we're going to talk about this. And so the first thing that we could look at would be, what would be the patient factors, or how looking at patient factors in this context could shed light on this pretty important problem that the literature on suicide prevention is trying to address with difficulty. And once we've understood better patient factors, we will also talk about clinician and dyadic factors. Does that bring up some glimpses of perhaps of a possible solution? So one important thing to address, obviously, when we think about patient's non-disclosure would be, in terms of patient factors, would be to understand patient motivations. There has been a bit of research, and by the way, one of the seminal papers on this topic was by Blanchard and Farber, and Barry Farber is a psychotherapy researcher member of SPR. So perhaps this is not, there are good reasons why the thinking went to motivations and patient factors for non-disclosure. And so we know that patients tend to be concerned about first hospitalization, shame, and stigma. They also tend to underestimate risk in that sense that they think, oh, I'll be fine, which will just go away, and I would rather not share. I was interested, again, in the spirit of psychotherapy research, to also wonder about patients' personality traits, patient factors. Are there certain profiles that are more likely than others to disclose or conceal ideation? And I will not get into detail into the study. And basically, this was a study where we looked at differential disclosures to clinicians on the one side and to researchers in the context of an anonymous study on the other side. And what we found was that extroversion and trait anxiety were making patients less likely to disclose to clinicians and more likely to disclose to researchers. In other words, it seemed like patients' trait predispositions, patients' personality was playing a role. Now, we can obviously think about the fact that it probably played a role, not just because of their personality, but because of the type of dyadic interactions that probably took place as a result of multiple factors, among which patient's personality. But let's have a look a little bit further, and we will get back to this point if we have time. We conducted a new study that also looked at patients' disclosure or motivations to disclose or not to disclose when they were experiencing a suicidal crisis. And they are asked about their reasons for disclosing or not disclosing just after making an attempt. Most of the literature was retrospective and talked about patients in therapy in general, saying if you ever refrain from disclosing, what were the reasons. And here we really identified a sample of patients who were just hospitalized. And the question was, why did you decide not to disclose suicidal ideation? And you can see that the main categories that we already know from the literature are here, with some nuances. Fear of consequences. Those consequences can be very diverse and not just fear of hospitalizations or coercive interventions. I think that I didn't want to spread it to someone else was very interesting. Stigma and shame, isolation, and impulsivity were identified. But as interesting as this is, I think that one of the contributions of this approach would be to say, well, it is not just about patients. What are the clinician factors that are going to impact disclosure? And it seems like the professional identity of the interviewer and the professional identity of the clinician seem to be related to patients' willingness to disclose. Here, I'm highlighting the results from the same study that I mentioned before with regards to differential disclosures to clinicians and researchers, with more disclosure to researchers. But we just conducted a replication of this study, this time with regards to disclosure in emergency departments. So when we think about that, emergency departments are really important settings where patients are screened. And if they're not willing to report suicidal ideation in these settings, it can have really important implications for access to treatment and risk identification. And as you can see here, patients were more likely in these contexts too to report suicidal ideation to researchers than to clinicians. And then we thought, well, let's implement the same logic and look at different disclosures to different types of clinicians. For example, in this case, psychiatrists only, or psychiatrists in general, versus nursing staff in inpatient psychiatric units. And here too, we can see that there are differential disclosures. In this case, most patients do not disclose at this point within the inpatient unit. It seems that they have, for some reasons, either figured out that in order to be discharged from inpatient units, it would be a good idea to refrain from disclosing suicidal ideation, or perhaps by the time they are in the inpatient unit, they are indeed feeling better and experiencing less disclosure. But in any case, if they disclose, it will be in the context of this study to psychiatrists rather than nursing staff, which can be very important because suicide risk assessments are very often standardized and do not take into account clinician factors. There is much more that we need to be investigated in this regard that I am hoping to investigate, or perhaps I will convince others to investigate in terms of other clinician factors. One thing that I looked at was personality traits. Would the clinician personality traits impact disclosure? In this initial study that we conducted, the answer was no. The manuscript is in preparation. So let's look very briefly at dyadic factors or interpersonal factors between clinicians and patients. And you will also pay attention that here I am not talking only about therapists. I'm talking about clinicians in general. That's also possibly something I could have highlighted when I talk about integrating the two domains, that a lot of the suicide prevention literature is addressing again, epidemiological questions and treatment questions, very often using acute populations that receive psychiatric treatment. In the world of psychotherapy research, we often investigate therapists and not necessarily mental health professionals from other professions. So let's look at dyadic factors. Denise, we can hear you, but I'm sure it's great. And so let's look at the relationship between alliance and patient's disclosure. Here, my hypothesis was that clinicians who experience a more positive alliance with patients would also probably have better chances that their patients would disclose suicidal ideation to them if they experience such suicidal ideation. And what we saw here was the opposite of what we expected, what we anticipated. Patients who disclose to clinicians only, as opposed to clinicians and researchers or researchers only, actually had clinician-rated alliances that were worse than those who did not disclose. In other words, clinicians rated their alliance with patients who disclosed ideation as being worse than with patients who did not disclose ideation. This finding was very surprising, but then in retrospect, we thought that it did make sense because clinicians rated the alliance at the end of the session as opposed to middle or start of the session. And in other words, their experience of the alliance was impacted by the degree, by whether or not suicidal ideation had been disclosed. So what this seems to talk about is probably that clinicians seem to have a more negative response and have a more negative experience of the therapeutic alliance after patients disclose suicidal ideation. And that basically brings us back to clinician factors that may impact ideation disclosure by patients. And we'll talk about these in the context of prediction. So let's now go to prediction. I know that I'm running through this really, really fast. I hope that it's still possible to take in some of the information. Let's look at patient, clinicians, and dyadic factors in risk predictions. For patient factors, there are a lot of tools out there to use for clinicians who are trying to assess, to estimate the suicide risk of their patients. However, these tools, most of these tools, if not all, rely on self-reported suicidal ideation. And we just talked about how this is a problem because patients tend not to disclose suicidal ideation. The second thing is that most of these tools are validated and remain the same across cultural groups and are not individualized to specific patient characteristics. So one of the new series of tools that we developed, and in that sense, I was really fortunate to have been mentored, as I mentioned before, by Igor Galinker at Mount Sinai during my postdoctoral fellowship, and we've continued to work together since then. Dr. Galinker developed this concept that I think is really excellent of suicide crisis syndrome. The suicide crisis syndrome basically collects a collection of psychological markers that are indicative of short-term risk for suicidal behaviors. And therefore, assessing for such suicidal mental state doesn't require assessing patient suicidal ideation, self-reported suicidal ideation. We're assessing psychological markers as opposed to self-reported suicidal ideation. We have conducted a lot of studies on the suicide crisis syndrome in terms of understanding the different domains of these different psychological markers and whether they constitute one unitarian construct. Of course, we have looked at prediction, and in this specific study from 2021, you can see that the tool, the SCI2, the self-report tool that we use to detect the presence of suicide crisis syndrome, did really well. You can see the 0.883 in the AUCs for the prediction of suicidal behaviors. This tool is actually embedded in a larger model of suicide that talks about the interaction between long-term and short-term risk factors that are both interpersonal and intrapersonal. We won't have time to go through this, but I want to mention it in case some people are interested. Now, why am I mentioning this besides this idea of assessing suicide risk without asking patients about self-reported suicidal ideation? I mentioned in the patient factors that we really need individualized tool for suicide risk prediction. And what you can see here on the screen is results from a project that is also a collaborative project that was born at SPR, actually, in Ottawa, after I attended a presentation by a collaborator, Jamie Delgadillo, who presented on Bayesian network analysis. And I thought, well, that would be a wonderful statistical approach to look at the relationship between the different dimensions of the suicide crisis syndrome across different cultural contexts. In this case, we conducted this study across in a very large sample, international sample of approximately 13,000 individuals. And what we saw was that indeed some of the domains of the suicide crisis syndrome were much more important in prediction of risk in some cultures than in others. You can look, for example, at social withdrawal, which was the number one predictor in Latin America, and it was not even included among the 5 most important predictors in Anglo-Saxon cultures. We decided to replicate this study within the United States across several different cultural groups. And the results were quite mind-blowing in that sense that, as you can see, for example, for the Black African-American sample, if you look at the area under the curve for the in-group model, we could reach prediction level that was perfect, an area under the curve that was 1.0, which is absolutely rare in the field of suicide prevention. It's more than rare. It is almost impossible, I would like to say. And so here the idea was really to think about patient factors and how to adapt or individualize existing tools, not necessarily by adding symptoms or by adding risk factors, but perhaps by looking at how we could rearrange them and develop individualized algorithms to establish the risk level of individuals. The idea could be applied to additional groups, age groups, based on patient characteristics, other characteristics such as personality, etc. I think that I still have a lot to cover, and I clearly will not cover all, so I'm going to go really fast about this question, which is that if we think about clinician factors, obviously clinicians, we are human beings, and therefore our emotional reactions to our patients is also going to impact how we assess them. And again, Dr. Galinger was a pioneer in this type of research. There are some really great papers by Barzila et al. And Michaud et al. And really the thought was that it is important to continue exploring those factors beyond anxiety and negative emotional responses that are going to impact clinical judgment. In just one word, in one study, I used AI-based simulations to see if the race of the patients would impact clinical judgment and how clinicians assess risk. And the answer was that it does impact clinical assessments, clinical judgment, clinicians' assessment of patients' risk level. So far, we have talked about the meaning and the importance of looking at patient factors, clinician factors, and dyadic factors, both in understanding patients' disclosure and how to address it, as well as in risk prediction. I see that we have only 2 minutes. So Tobias, would it be worth just leaving the intervention's effectiveness on the side so that people can ask questions, or should I share brief conclusions about that? How would you like us to go about it?
If you would like to share some brief conclusion, if it's possible in 2 minutes, I don't know, then we can do it. Otherwise, we should go to the questions.
That sounds good. So I will focus on clinicians and dyadic factors, and I will just share the results of a virtual patient simulation clinical training where we decided to look at the impact of a training that is geared towards clinician self-regulation on patients' outcomes throughout treatment. So we didn't target patient factors, we just targeted clinicians' anxiety, and self-regulation. And what we can see is that both in terms of the alliance, patients of clinicians who participated in this training reported better alliances. We can see that their levels of suicide risk assessed using the suicide crisis syndrome inventory also decreased, and their suicidal ideation also decreased more over time among those whose clinicians had received a training. I've also developed a new integrative intervention. I won't get into it too much. I would just say that we're implementing the same type of logic where we try to combine a way to address patient, clinicians, and dyadic factors in new interventions and new clinical trainings that we're designing in different settings. This one hopefully will take place in the military. This one will take place in acute clinical settings, in a hospital setting. And another one that I didn't mention here is taking place with students, PhD students in the US. And with that, I am done.
Thank you very much, Sarah. And I think it's very impressive that you could integrate all these factors in such a short time. I think it was a clear message, and thank you that you were talking with us. Are there any questions for Sarah? No questions right now. I think we could end today maybe 5-10 minutes later if there are more questions. So my question for you, Sarah, would be, I really like that you pointed out the part where we have got some room what we can do as therapists. What do you think is most important for the training for the upcoming therapists? Where should they take attention to? What is important?
That's a really good question. I think that there are many areas that would be important in training. The ones that I have in mind and that I am focusing on, I mentioned one which is clinician self-regulation and clinicians' capacity to interact meaningfully with patients, despite the fact that these interventions and risk assessments have very high stakes that are anxiety-provoking for clinicians. Another area that I think is really important to focus on when we think about engaging patients and doing better is how can we help patients reflect on their own suicidal crisis in a way that is compelling and in a way that is meaningful and does not feel like we're just interrogating them and asking every time that something happens to report and to go through a set of unpleasant procedures. And so in that context, that's a part that I didn't have time to highlight so much, but this ISCAN's treatment was very much about this, about helping patients develop individualized models of suicidality. I think that one of the questions before was about suicidal crises are not just about internal factors, they are also about cultural factors, about the interaction with the environment. And so the thought was, how can we both use empirical models of suicide, but also use them as anchors in which patients and therapists can collaborate, develop individualized models of suicide that will then provide templates for intervention. And so in ISCAN, that's what I tried to do. I was really pleased to see that clinicians responded very well. I conducted a pilot feasibility study, and clinicians were really thrilled to receive some help with conceptualizing suicide that was on the one hand structured enough to help them feel less anxious and to help them feel effective, but on the other hand flexible enough to allow for this individualization. So I don't know if I'm answering your question.
Yeah, you do. I like the idea of the integration of flexibility and the reflecting part. I think it's very important. Thank you. And I see another hand, Denise.
Yes, thank you. Thank you very much. I couldn't agree more on the need to individualize treatment. One life is too important to give it an assigned protocol. No, I would like to suggest that complementing your very interesting work on clinicians and in training, but I think that emergency room personnel should be trained too. There are two pieces of research which back up very importantly. Roy Schaffer, an expert in adolescent suicide in the States, found that the mean time of waiting in the emergency room for attempted suicide was 6 hours. 6 hours. And we have in my country, in Uruguay, research done by the Ministry of Health showing, even in a country which is very kind and nice and Latin and everything, how attempting suicide brings along very heavy maltreatment from the personnel in the emergency room. Sort of, you're cheating everybody, or you're not brave enough, or don't fool us. I mean, kill yourself. So this is, I think, an area which is unexplored. And in the terms of research and in the terms of intervention, emergency room are the first personnel, are the first message people get from the world of whether life is worth it and whether they are worth being helped. Thank you.
Thank you. This is such an important point, and I couldn't agree more. These clinician factors are going to be critical, not just for therapists again or clinicians once that the patients are hospitalized, but obviously in emergency departments with a wide variety of medical professionals that are going to interact with patients. So I'm taking notes for the few next studies. Thank you.
Thank you very much. I think we can end with a question in the chat from Anna. I'm not sure if Anna is still in the meeting or if she had to leave us.
Yeah, hi. Thank you.
Right.
I'm still here. I just have a kind of poor connection, so that's why I posted it into the chat. Yeah, I just I wanted Andrea just to give some ideas about how they were managing these confidentiality issues, because when you are using this large language models that are available, like ChatGPT or something like this, you obviously need to upload some confidential information of your clients or patients, and I'm sure they fix it somehow. So I'm just wondering, like, what was their solution?
Yes, thanks for your question. And by the way, in the meantime, I had the opportunity to quickly check also about the model that we are using. So it is indeed the GPT OSS model. And regarding your question, we are in that sense not exactly uploading sensitive information because we are using a local model. So everything runs on our servers here at the University of Zurich. So everything complies with data security standards. And we basically keep everything internal and nothing is uploaded in that sense. And we also, of course, work together with, and I have not mentioned that yet, but we work together with a software development company called Pathmate, and they are, of course, also supporting us with all topics on data security because they are the experts in creating digital health solutions. So just to give you a quick overview on how we handle things within the Multicast project.
Yeah, thanks a lot. It sounds very impressive, and good luck.
Thank you.
Okay, yeah. Thank you all for attending us, for your questions, and Sarah and Andrea, thank you very much for presenting and giving us these important and interesting insights. Yeah, I saw another post in our chat. It's no question. It's just a reminder that the registration for the SPR this year in Osaka, Japan is still open. And yeah, I would be very happy to meet you there. And yeah, I would like to end this meeting now. Hope you're all having a nice day, a nice evening, and yeah, see you another day. Bye-bye.